time. We'll look forward to hearing our next interview with Dr. Sean Nork on the association between supracondylar, intercondylar distal femur fractures and coronal plane fractures. Hi, Dr. Nork. It's good to see you. Thanks for agreeing to talk to us about the article that you're first author on with the association between supracondylar, intercondylar fractures of the distal femur and coronal plane fractures.
Nice to see you, Mike. Thanks for having me.
Likewise. So the first session with this AO Journal Club we're going to start out with is what prompted you and your partners and co-authors on this paper to start this study or to perform this study?
Well, I think more than anything, given kind of the year of this study, we just didn't have a great understanding for the fracture patterns that we were seeing. The fracture patterns that were typically showing up at Harborview hadn't read the textbook and weren't limited to a single intercondylar component with or without comminution. So our initial impetus was really just to gain a better understanding for really describing fracture comminution of the distal femur and the common fracture configurations that we were seeing. Also have to remember that at that time, it was where we were transitioning to the use of locking implants. Locking implants had come out just a few years before. We'd been treating distal femur fractures with angled blade plates or non-locking lateral plates. So the relationship between coronal plane fractures and the implants themselves, we thought, was becoming increasingly important. So we first wanted to understand the fractures, but then we also wanted to know how common are they and are we missing them? And should we be using different imaging studies? Because at the time that we started this study, when we look back retrospectively, we were getting CT scans on a minority of these injuries, but as the study progressed, it became much, much more common because we were seeing coronal plane fractures much more frequently than we initially thought, I think, at the start of the study period.
Okay. That's part of when we talk about some of the questions there, how has it changed your practice? So before this and initially, were these primarily being worked up with just plain x-ray? Was obtaining a CT scan a much bigger deal 20 years ago than it is today in terms of timing and getting the patient to the OR? And what you said you changed kind of how you're looking at these. What other imaging studies were you getting now that you didn't then?
Yeah, I think part of it was to almost make getting a CT scan virtually the standard practice for evaluating these, just like we would with a tibial plateau or a pilon fracture. And at the start of the study, really a minority of patients were getting CT scans, and we had missed coronal plane fractures. And by the end of the study, about 3/4 of patients were getting CT scans, but we still don't always see the coronal plane fractures on plain film imaging, which is probably less worrisome if it involves the lateral condyle, but I think more worrisome if it involves the medial side, which we wouldn't routinely see with our usual exposures at that time.
And did it change anything in terms of your surgical approaches or with your preoperative planning? What things were you doing differently after you found the results of this paper?
I think we were much more aware of the existence of medial-sided coronal plane fractures. Although it was still a minority of patients, it was a complete disaster if that was missed. I do think it got us thinking about alternative exposures or which exposure would allow us to see the entire joint. And I think it made us more aware of fixation strategies and the conflict that we would frequently see with placement of implants to stabilize coronal plane fractures, and how would that interact with lateral fixed angled constructs. Although that wasn't the motivation of the paper or the point of the paper, I do think it started to generate all of those thoughts and concerns and how to manage those as we moved moved forward on treating complex distal femur fractures.
Can you kind of talk about that reconciliation of implants that you went through in terms of what was the iteration of how you started fixing them and then where you are now with terms of that?
Yeah, so when we first started fixing these, we were using much larger implants to stabilize coronal plane fractures because they were displaced articular injuries, and that was more our habit. And then we were realizing to try and get a lateral implant in place, a lateral plating construct that would span the metaphyseal area, these larger implants to stabilize the coronal fractures were taking up a lot of that valuable real estate. So I think with time, we started to use smaller and smaller implants to stabilize coronal plane fractures to allow room for implants on the lateral side or in the future, even on the medial side, so that we could get adequate fixation into the articular block. So once again, it wasn't the point of the manuscript, but I think it started to generate a lot of thoughts with regards to how we could optimally treat these, prioritizing the joint, but still allowing ourselves the ability to put on a lateral implant to stabilize both the articular block and the diaphysis.
In terms of when you look at this manuscript, or was there things at the time that you felt, or what do you feel are the limitations of how this manuscript was developed or this paper?
I think probably the biggest limitation is I don't know that our patient population is representative of distal femur fractures that one might see at a hospital where the energy of the injury is not quite as great. But I think that's okay because I think what we demonstrated was a high incidence of associated coronal plane fractures. And I think encouraging surgeons to really evaluate these with CT scans and be aware of them is extremely valuable. And I'd rather them be looking for these injuries in a very large percentage of patients, almost 40% of patients in our series, even if they only occur in 20 or 25% of the fractures that they're seeing. But I don't think that our patient population is really representative of what someone might see at either a community hospital or a level 2 center where there are fewer open injuries or lower energy supracondylar-intercondylar fractures.
Okay. If you were given the chance and you could repeat this type of study, would you? And if so, what would you change about it?
Yeah, so I don't think it probably needs to be repeated now because I think so many of the conclusions of it are routine and well known in 2021. Of course, we should get a CT scan for these, and of course, they're more common in open injuries, and we do see coronal plane fractures of both the medial and lateral side, and the lateral coronal plane fractures are more common. I think the study itself doesn't need to be redone, but I would like to have maybe expanded on how to use that knowledge to come up with strategies for fixation. Which surgical approaches are optimal with which patterns? Can you combine surgical approaches about the knee and distal femur fractures for really complex injuries? Should you start with a parapatellar approach and use increased knee flexion to assess the joint intraoperatively, depending upon the complexity? So I would have loved to have expanded on the surgical techniques for fixation, but the point of the original manuscript was really just to describe the association, recommend CT scans, and increase awareness of the fracture patterns that we see.
I know that in some of the other articular injuries, like distal tibia plafond extension with distal shafts, like where HSS has looked at the use of MRI, like it's just, do you think this is an injury where addition of an MRI study would be of any use or utility? You know, looking at these types of injuries if they're missed on both CT scan and plain film.
I would give it a perhaps at best, but with no data to back that up. We're just not seeing significant instability after supracondylar, intercondylar distal femoral fractures, whether or not they have associated coronal plane fractures in comminution. And I think with heightened awareness and scrutiny of CT scans, I just don't see where we're missing these injuries, especially now that it's almost routine to even get 3D reconstructions of CT scans so that we don't have to try and generate an understanding of these fracture patterns in our mind. I think that's probably
Certainly help
made
the library.
exactly. I think it's made an understanding of these a lot easier as well. So I think with that as an addition to standard CT scans, I think we have a pretty good understanding for both the morphology of the fracture, and then that will generate an intelligent fixation construct.
Awesome. I guess my final thought question to you would be: when you think of distal femur fractures, is there a paper or surgeon that you think of that impacted what you do or how you thought of these?
Well, I think my approach to these, like with all periarticular fractures, was always influenced by my senior partners. So Dr. Steve Benarshka and Brad Henley, who were both co-authors on the manuscript, I think really taught me and all of my co-surgeon colleagues and friends to have a real appreciation for the complexity of these fracture patterns. And so I think conversations with them really motivated me to try and understand these distal femur fractures in more detail for sure.
Awesome. Well, thank you so much, Sean. I really appreciate your time.
Yeah, thank you, Dr. Tallarico. Hope to see you soon.